I would like to share with you some interesting thoughts about dorsal preservation. Years ago, I was doing spreader grafts, spreader flaps, and everything was very, very important. I still do in some cases, of course, spreader grafts and spreader flaps. But then I met some bad company, some bad guys, and I think you know a lot of those guys, and especially Eve and Roland that pushed us into this trouble with the dorsal preservation is 5-6 years ago when we started to exchange, and we did a lot of dissection in Budapest, in Hamburg also, and in the knees to try to understand how can they preserve dorsum? How can you suddenly make that your dorsal aesthetic lines can stand there and that you have a beautiful tower, but you can remove a piece of the building and you can still have this beautiful tower. And a lot of talks with those guys. Barish Shakir. Barish is very, very important in this whole story. He is a thinking man, and his impact was also very, very interesting in this story about dorsal preservation. But the people see what there are meetings that they're seeing with your beautiful picture, your best results, but something they should see only some, also your problems and your troubles. And what I'm personally afraid of, this is how we started. Actually, dorsal preservation, everyone knows. It's a story from 1890, I think 5 in Boston. It's more than hundreds of years. And then some people are still doing dorsal preservation in Brazil, in a Mayo clinic like Oren Friedman and Jean Kern, Yves Saban. And there was a moment when everything suddenly changed and we started to do it, but there was some problems. And what I'm personally afraid of, what a lot of things were happening, especially in the beginning, to get this step in a radix. All the sections are by Peter Palhazy. And if you remove a big piece of cartilage, in some cases, you're going to have a specialist step in this area and also in the supratip area. We're going to talk about supratip later. It's very, very interesting. And this step can be a big. If you take a look on this CT scan, this is a huge, this is a bone impaction. If you remove with a Blakesley or Takahashi a huge piece of bone, and if you say, okay, I'm going to press it, you're going to get into trouble. And what people are doing, you see this big step. What is happening? The people started to smooth this step, and they just to remove the bone with a chisel, and suddenly your radix became elongated. And that's what Aaron Cousins calls infantilization of the nose, because the people, again, the nose like a baby's, take a look where the radix is. And it's not a kind of surgery what we would like to have. And this appearance it's more than artificial. So I started to do so-called subdorsal triangular dissection, trying to prevent any possibility that my bony dorsum drops. And I started to cut it mainly with a piezo. I'm using piezo, and I'm a big fan of it. To do a cut in a radix area and to go directly below the dorsum. This is very, very important. We're going to talk about it, to keep this place. And then I'm going to take a piece by piece below the dorsum, so I can create so-called hinge effect. And I have this kind of instrument. This is a piezo rasp, hockey stick rasp. You can stick it, but you can also take some kind of scissor if you don't have a piezo, or when you already remove the whole pyramid, you can lift it. And if you have a burr, you can burr it in this area below. And so you can create some kind of hinge in this area, which is very, very important. And if you take a look exactly here. This is a hinge effect. This is where it should work like this. I think this is clear. And this is where I did this hinge effect also with so-called partial spread of flaps on her. But if your hump is bigger, what you can do, because that's what we are doing, it was a so-called Gola Saban style. Yves Saban, he did a great, he's a great teacher and he's big impact. But if you take just a parallel strip, it's going to go in a deeper direction, but your hump is going to stay. And my friend Goran Lazovic, I just talked to him 1 hour ago. He's a plastic surgeon from Belgrade. He wrote with Roland this very, very interesting article about V-shaped and S-shaped bones. And you can take if you have a S-shaped bones like this, you can use this hinge effect, take a small strip of bone, and you're going to get a good result. But I ask myself in some cases, okay, if I have this S-shaped bone, this could be a slight problem for me. So I tried this cotyle rhinoplasty a few times, but I still need septal extension graft. In many cases, I use lateral cuirass struts or articulated rim grafts. And there are two problems. In a cotyle, Valerio Finocchio changed the name. He did a slide changes there and call it SPQR technique. He's also a very, very good surgeon. But the problem is you rely only on the 1 or 2 stitches here in this area, and your septum literally can't go back. This is a problem. And when you stitch, what kind of stitch, it can happen. Then you are going to get a saddle nose. And in some cases, you don't have enough cartilage for the grafts. You don't have it. And this is a big problem. So I started to think, how can I use those possibilities to stretch the pyramid, but to get enough cartilage? So I combined a few techniques and made my cut. This is exactly where the key area is, exactly where the bone ends. The first cut, I mark it with a needle and go approximately 8-9 millimeter below. And then this is here the point few millimeter before the septum end. I make this triangle. It's already cut it with a piezo in this area. And I connect this cut. It looks a triangle. It's like a small subdorsal cotyle or subdorsal. It looks like a Z flap. And this gives me an option to flatten, literally longitudinally flatten the dorsum, because it's a completely different movement. You pull it, you will see the short video, and you have enough cartilage for your transplant. You have enough cartilage for a transplant. I overlap it. There is no problem. I have 700 cases with this, and I have never, ever seen any problem. If the septum is maybe thicker, you can take a burr and to smooth it. This is not a problem. And then you should gradually to take a piece by piece of the septum below, and be sure to do it to take the whole part. I will come back to it. And to take a small piece and to overlap it and fix it below. This is nothing new. And everything started in Brazil. Everything started in Brazil. And it was Ishida 20 years ago. And Carlos, he gave me his article. And they took the strip of it and they fix it. They put a few sutures. And Carlos explained me how they do it. Now Sam Moss is doing the same procedure. Then it was interesting that it's a Devesh who did this. It looks like a brick. And this is here remind part. It's a cartilage here in this area. It's a still cartilage. And they fix it below. They fix it below with several sutures. It looks like a quadrangular brick. and it fits exactly in this place. 1.5 years ago, Guxel, my close friend, sent me, oh, I have something interesting. One guy from Jose Neves, he's doing this. He's taking a piece of it exactly, and it fits like a Tetris. And it's looked like this is like, for me, Neves, what he's doing is a big Tetris. This is a small Tetris, it's just pulled up. But for me, it was like, okay, if I'm going to cut the cartilage exactly and to fix it, it's a nice idea. But it's not going to have a vector, moving vector, which I need. So I started to use this part. But the problems are also, if you're using this kind of quadrangular dissection, and this is an interesting part of the story, you're not going to have a problems in this area in the radix. Also your supratip, and several friends of my surgeons, when they are on, they say, look, Milos, I have a problem, it drops. And this is why this subdorsal Z flap, it's a sliding, and you have two parts. They're supportive. You have a here in a caudal, actually a cranial part of the bone is supporting, and your whole pyramid is literally sitting on the septum. This is your second supportive point. So you don't rely only on the stitches. And this is the interesting part. There's no chance that if you're doing it properly, there is no chance that that is going to be the drop in the supratip area. Again, if you're doing this quadrangular kind of resection, the possibility that you get a drop in the supratip area, sometimes it could happen. So it's better to have two safe points. So this is like a bridge, and you should remove, I will explain later why you should remove exactly this subdorsal area, this subdorsal keel. This is from Dean's. Dean made a great video, new article is going to come. He fixed it. We are working together on this technique, and he did a great video about it. And take a look, this is Dean doing a video. I tried, unfortunately I had a patience when I had only 1 day. I wanted to do it, but I had very, very thin skin. Patience, so, and the skin pulled in. But Dean's video is a perfect, and you can understand exactly, he's pulling it now, and you can see how it works. He pulls triangle, and you see how it works. And this is from an article which is going to be published in a few months with Aaron Cousins. You see how it works. It's a longitudinal stretching. And if there's a less septal cartilage, instead of cutting it 90 degrees, you can change your angle. You can change your angle. And so that your angle of chondrotomy is more open. So you can do a longitudinal stretching of cartilage. Very important thing is the releasing of lateral key area. And that's why I think that many surgeons, they're contributing, they're willing to work together. This is a Guxel. Actually, Ishida did very, very interesting, also very, very interesting part in his maneuver. Guxel overtook this Ishida maneuver for this opening of the pyramid, and he's releasing lateral key area. This is from this publication. This is Dean's graphic designer did it, and you can understand, you can see it better. Even I love these pictures. With a scissor, I like to divide this connection between upper lateral cartilage here and the bone. You don't have to cut it. You release it approximately till, I would say, where a key area, it goes into the lateral key area, and you just pull it. So all those elements are important, so you can flatten the dorsum, and it works, because I have a lot of patients from a Middle East, like from Iran, from a Turkey, from Afghanistan, from Iraq, etc., etc. And those people have, I would say, different noses than the people from Korea. So I have to deal with a big humps like this. And this is from Peter Palhazy, that we did the dissections together with him. You can see exactly, this is This is where, this is a bone, and this is a key area. And this is where you go with your scissor, sharp scissor, and you just divide. Try not to cut. Just divide it. And this is this ballerina maneuver. And you pull it, this part in this area. And you can see it, these patients before and after. Before and after. Or like this. These are bigger humps. And if you try to push it, you will get an infantilization. So you should flatten the dorsum. But if there's still a hump, okay, then you have a problem. And what I did, I said, okay, being a Serbian obliged means you should be brave. And I said, okay, I'm going to do something a little bit different. And this is, I'm going to release a key area for a 3 millimeter. So it is going to work like a joint. It's going to slide. My cartilaginous dorsum is going to slide below the dorsum. And you can see it here. This is a bony dorsum, and this is a cartilaginous dorsum. I release it with a scissors, and then a little bit with a freer, sharp freer. So you see the gap here clearly. Pull it up just to show, but not a whole, just a 3.5 millimeters. So it can flatten better. 5.0 vicryl because of the resorption, and you should fix it. It's an interesting option. It's a joint, we call it a joint procedure. A lot of names, and a nose is like this. Yeah, that's how I can do it. In 2 cases, there were several cases, but in the 2 cases, I had a slight, small irregularities in this area with the people with very, very thin Scandinavian skin. And in the last 3 or 4 years, I'm using this chopped diced cartilage mixed with a high concentrated fibrin. So I'm creating a layer of fat, approximately I would say 0.81 millimeter layer. So it covers all irregularities and fat stays there. So in these cases, when I'm doing this joint procedure, and I use the fat to cover it. You can use temporalis fascia, whatever you want. And this is her after. Looks much better. Male patient, very nice guy. One of my first patients for this joint procedure. So you can release the nose, and you can do this procedure, release 3 or 4, not full release because it's going to collapse. You can suture it, but it's going to collapse. The other problems is the white dorsum. What to do? There are several options. We are working now on a few options on it, how to deal with this with a white dorsum. Can we do dorsal preservation let down procedure on dorsum like this? And you can create, either go with a piezo, with a very, very sharp instrument, or if you don't have a piezo, do so-called glass cutter technique. Take your 15 blades, 1 or 2 15 blades, and scratch it, make a lines, osteotomy lines, so you can create some kind of green stick fracture. Just very, very gently squeeze it, very, very gently. And then you can put so-called doorstep graft. Take a piece of ethmoid plate or a piece of cartilage, just to prevent so-called bone splay, because in some cases the bone is going to go like this. And if needed, you can use this bony step. What you can also do, doorstep graft. What you also can do, you can take a burr or a piezo, and instead of cutting, you can try to take a piece, slice by slice, of the surface of the bone, so you can mold the bone literally. In a patient, they have some of them, the bone is a little bit different, so you can mold it and you can place your doorstep grafts. They're working now on a different kind of osteotomies, and maybe in 4 to 6 months, maybe there'll be some interesting news for all of us. What we can do, and that's her before and after. Before and after. I like this natural. Try to make a natural result. There's some problems which can occur if your sternum is a little bit more straighter than in this picture like this, where it's my patient. It's my patient. She doesn't look happy. What happened? There was an axial shift, and you can see here in this area that the dorsum, my dorsum went down, and it stayed some kind of so-called subdorsal keel. It stays piece of bone stays there. I couldn't move it. You can see it here better. This is her dorsum, and when a piece, and this stump, subdorsal stump or subdorsal keel, goes on the one side, and it stays crooked, you can't push this and bone after you remove the cast, and you don't see it always. And this is a big problem. I had a few patients with this, and I didn't like it. I thought to myself, okay, what can I do? What can I do? And I said, okay, what can I do is to do a precise subdorsal cut, precise keel removal. Like in a boat, there's a keel, and you should remove this stump. You should remove this keel below exactly and clearly. I do it with a piezo. You can use it also with a chisel, and then to take a burr. And at the very end, it should look like this, that your bony dorsum is sitting on your septum, which has other advantages. Why? This is also my patient. She's got a recurrent hump. 1 month after surgery, she came to me and, doctor, what's this? We tried to push it, it doesn't work. It pops up. And this is when we started to do dorsal preservation, the most common problem on all of us, and while dorsal preservation was kind of technique which was a little bit problematic because of this recurrent hump. And what I realized, if I started to do this subdorsal keel removal 8 months ago to clean it clearly, everything what I have below. And I start everything what's below the bony part, you should remove it because there is no function. This whole stump below, it doesn't keep a shape of cartilaginous hump. This is important, that everything what's below the cartilaginous part, you need to keep it. It's definitely necessary. But everything below, it's not necessary. Remove it. Take your Blakesley. You can take your burr. You can take different instruments, whatever you take, but make it clean. When you remove your pyramid, when your pyramid is mobile, lift it with a speculum, and you can see exactly below this area. This is this area here, subdorsal, and clean it. Take your time. And this is the blockage area. I have 98 cases with literally no recurrence hump. Again, almost 100 cases since I'm doing this with almost no recurrent hump. And this could be a solution for the biggest problem in dorsal preservation, and the most common complication is recurrent humps. This subdorsal keel removal is the answer, in my opinion. I have just 8 months experience, and people that are doing it, and I think this, I hope that in the future, next 2-3 years, when we present longer data, this could be an answer for this. You can see this is also from this future article going to be published with Dean and Aaron. You clean everything below. This is a beautiful graphics. I love these graphics. And this you can remove it. All this cartilage below, it's mainly cartilage. And this is going to have, you can leave the small space here, doesn't matter if this part is okay, but keep it and it should fit on your septum. You can smooth it, as I said, with a burr. And there's a problems, I say, in the super tip area. And even if your tips are smaller, try to do this small, like a oval shape, semi-oval shape. Don't make cuts like this, like I showed to you. These cuts, quadrangular cuts, can cause you a problem in the super tip area. And if you have a smaller humps, you can do a dissection like this, where this point and this point, they're literally sitting on the septum. That you have a two supporting points, and this is which is going to help you a lot. But clean everything below your bony dorsum, everything. So this is before and after. She's South American origin. And I will go back to the cochlear rhinoplasty. And again, one of the biggest problem is it's this saddle nose risk with when a suture, one of the sutures can just open and it's going to go back. I was talking with Dean, what he can do, and we came up with an idea to do so-called a stopper. And this is a funny thing, because instead of taking the basal strip, the full basal strip, whole, you leave a piece in the front, literally, which is going to go in the front of the spine. And it's going to lock. This, you make a notch. And Dean was doing his septal extension graft, if you remember, which goes below the spine partially, make a step. So we came up on the idea, hey, why won't we do this? And this works in several cases where the spine is in the front. If the spine is not the front, you can put the other options. But this is going to keep your if you want to do this cochlear procedure, as SPQR procedure, this is going to prevent these backward movements. It's very, very interesting. Rasping the bone, I don't rasp the bony cap or a bony layer completely. Why? Because I need sometimes that this bony layer keeps my upper lateral cartilage, these so-called horns, below. Because sometimes they pop up and then you have a problem. You rasp your dorsum, and after 10, 15 minutes, you finish your surgery, you put your cast, and everything is under pressure. And in some cases, it pops up, it goes up. And this could be a problematic because you have a hump again. And a solution could be that you make some kind of, that you don't cut, you make your spread out flaps a little bit different. The cut should be going below the bone. We gave an other name now. And you can do the partial spread out flaps. Don't cut caudal part. Other thing is, if a radic step occurs, what you can do, and if you have a patient, you know the skin is here is very, very thin. You can do several kind of grafts, but what I personally like to do is so-called PRF, platelet-rich fibrin, with the cartilaginous scales. You take a highly concentrated fibrin, make a centrifuge, and there's a lot of growth factors inside, like vascular endothelial factors, etc., that support survival of the cartilage. And like those scales, they look like a bricklayers, they go over, and especially in the thin skin patients, they're overlapped. You don't see any particles there, bigger particles, and they're overlapping, and you connect them with the patient's own high concentrated fibrin. Everything is green technology. There's no addition of some bovine fibrin or anything else. So, and it looks good, and it adapts to the underlying surface. And it's a gel. You create gel. You put your cartilaginous scales of fine-diced cartilage, and it adapts to the underlying cartilage. Take a look how it goes. It fits perfectly. And because I don't use fibrin glue, it's a there's a bovine fibrin inside. It's a rigid, and it doesn't adapt to the underlying surface. So you can read in this article, which we wrote several years ago, how it works. And in these cases, I needed it. Hump occurs several years ago, and after several years, it looks much better. I added here, I needed a radix graft before. So I did some kind of balanced rhinoplasty. I supported radix and then did a dorsal preservation or let down procedure. So this is article, I'm very, very honored to write this article with Dean, who is a great surgeon. And exchange of ideas with him is spectacular. And we are going to publish, I hope so, in 2 or 3 months, a new article with some new ideas. Dean did a great, Dean has a great idea how to deal with a patient there where you have to do a caudal and the caudal part of the septum is broken. It's very, very interesting. I recommend to you. So this is the first part of my lecture, and Fernando disappeared, and I would like kindly to hear what kind of question do you have.
All right, we have.
Oh, you're here.
Yeah, I'm here. It's amazing because you're giving the lecture, and we have the Interyomi, Roboti, Ishida, Dr. Honshi, and Baris. They're all.
Baris is there.
Yeah, they're all with us.
Daniel Avengan is there. A lot of Baris, Nasilson. Hi, guys.
Professor Miller, do you want to proceed with your second part, or do you want to open for questions? How do you want to do? How do you?
A few questions, just 2 questions, because we will move further.
Okay. Professor Dr. Interyomi, Roboti, Ishida, Dr. Honshi, Baris, do you have any questions or comments? Maybe would be nice if you could talk a little bit about. Feel free to turn on your micros and ask.
I can see Dean also.
Yes. Hi, Dean. Hi, how are you, Dean?
Hear me?
Yeah.
Good work, Milos. Good work.
That's it's your influence. Never so good. That's your influence. And the older guys also, and from Barish and from other guys. But I have to thank you for your collaboration.
Hello, Milos. It's an honor to listen to your lecture. And Nakamura, thank you for this meeting. And also, hello to Dean Torimi. I took lots of tips. Thank you very much. And I like that step, creating a step to fixing the quadrangular flap to the spine. Thank you very much.
It's interesting. It's interesting.
Yeah, it's very interesting. And I'm listening very carefully. I'm going on. Thank you very much.
Thank you.
Thank you, Baris. Thank you for participating. You're present in many times, and it's amazing. Thank you, my friend.
Thank you.
All right. I have a question for maybe Dean and Professor Milos about this step. I think it's. I also thought it was really interesting because sometimes I have difficulties on fixing the caudal portion in caudal or SPQR in the nasal spine. And what I've been doing in maybe 5-6 cases when I have a lot of difficulties, I create, it's basically the same idea, but I create a little knot. I create a little notching on the on the inferior part of the caudal septum, and it really actually I learned from Dr. Yumi because when he does a lot of structural rhinoplasty and he wants to fix on the nasal spine, sometimes I've seen Dean creating a little notching to fit on the inferior nasal spine, and I just transport this idea for the SPQR, and the only thing that I noticed, I have to calculate. I cannot remove a big strip from the inferior part because I have to count with this little notch that I'm going to create.
You have to calculate a piece of strip.
Yeah.
How long should this piece of strip be? But you have 2 minutes, and it's better to invest 2 minutes more time than to explain your patient's 10 time 30 minutes. Why didn't you invest these 3 minutes?
Yeah.
And it's better. Take your time. Take your time. No one on the very end of your surgery is going to ask you how long did the surgery take. And all those guys, they're doing rapidamente. They have either they invested time to spend with their families or the friends or whoever, or they're going to spend a lot of time with the patient explaining them why they didn't spend enough time in the surgery. The most important thing is the result.
Yeah, yeah. And even doing with this, even doing this shape on the caudal portion, you put 1 or 2 sutures. How do you do that?
It's enough, and sometimes you don't have always to drill the hole.
Okay.
Because you have in the front of spine, you have a very often, not always, but you have often so much tissue in this area, so you can literally pull the patient's head when you pull the suture. So if you grab your tissue with a 40 PDS and you feel it's a strength, you don't have to drill the hole always.
Okay.
It's
yeah.
Easier.
And another thing that's interesting here in Latin America, we have a lot of short septums, and with this maneuver, we create some extra support on the caudal septum, and I think it helps. Yeah, just like a extension, natural extension of the caudal septum. I think it's really nice.
Definitely.
Okay. Ishida, do you want to comment something?
No, I'd just like to congratulate Milos for the fantastic lecture. Congratulations, Milos. How are you?
Muito bom. Thank you very much. And your article and your thoughts are great. That's there. Everyone is contributing with one step of the stairway to every one of those great surgeons. And what I'm sorry, which is a very interesting. It's Enrico Rabote's contribution with each hybrid kind of surgery. You should read this article. I read it several times, and I'm using it from time to time because Enrico he's doing Ishida style, but he's opening, in some cases, the pyramid and adjusting upper lateral cartilage. This is a very interesting contribution. And I can tell all of you, if you have a time, take a look exactly, and there will be cases. I use it in 3 or 4 cases where I needed to change in a pyramid. And it was a very useful for me.
Amazing. Okay. Any more comments? Maybe Dr. Rabati or Dean, any more comments before we proceed to the second part?
I have a problem with, hello to everybody. I have a problem with my video, but it's such a pleasure. And this was so great, Milos. It's unbelievable.
Thank you very much.
But regarding your kind note of my little cartilaginous dorsal split push down, I really think that opening the mid-vault is so relevant, even in full preservation. I don't see any reason why you don't open it. You can open it and play with mini spreaders, and this has expanded my indications so much.
Yeah.
I couldn't agree more with you with the worry that the full caudal doesn't give me enough material for grafting and leads me to some potential instability. I love this notch modification, but it depends where the spine sits.
Definitely, definitely.
Yeah, I will try your mini cuttle. I think this is just and taking all the bone out proximally. This really is something I want to try. You know, it's all bits and pieces. And yes.
It works. There are a lot of techniques, and you can't have a technique which fits all noses.
But opening the mid-vault is, for me, so important because these upper lats, sometimes they push up. I just release them and then I just take really 5 minutes with 6.0 PDS. I do not see why preservations considers as some preservation is considered as a dogma, the fact that you should not split the mid-vault anatomically and then just suture it back.
Exactly. No one is going to get burned. No one is going to get burned because of opening the middle wall.
Well, you need to open the nose, however, you can't do it closed, right? Yes.
Definitely not.
Well, thanks. I'm just enjoying this so much. I have a problem with my audio, or video. I solved it now.
Thank you so much, Professor Body, for being here. Dean, I'm sorry.
Enrico is a great thinker, and I enjoyed. We had I don't know how long we talked. More than 1.5 hours. It's like playing instruments where the people are talking about and giving one idea. It's a pleasure to talk to such great minds. That's great.
Yeah, and it's amazing to have all you guys here. It seems like the best panel in a big meeting. Thank you so much for being here, everybody. Dean, do you want to comment something?
Yeah, just 2 quick comments. One is sometimes when we do these noses and we're doing a caudal technique, the nasal spine is off midline, and that really creates a difficult problem for us. And so you can use a 5mm osteotome, and you can actually shift the center of your spine by slightly splitting it, and then move that notch that you have on the bottom of your caudal flap, caudal to the spine, as Milos said, and then fix it with a couple 4.0 PDS sutures. Very effective way to shift the true midline at the base of the columella, which we need to do on occasion. And the other thing is, I think one of the most powerful aspects of the Z-flap that Milos talks about is, of course, the deviated nose. When you have your axis deviations, that's the thing that shocked me the most with respect to moving the dorsum around and correcting your deviated nose deformity. I mean, we all talk about correcting the dorsal hump, but I think even a greater advantage of using these dorsal preservation techniques is correction of the axis deviation. It's unbelievably powerful, and it gives surgeons, rhinoplasty surgeons, a more efficient as well as a more effective way to correct the crooked nose.
Amazing. Yeah, amazing. Professor Milos, do you want to proceed with your lecture?
Would be good. We can go further.
Yes, please.
And
thank you all again. Baris, Dean, Enrico, Ishida, Honshi. Thank you so much.
I'll try. So to create a beautiful tip is not always easy, and there's a lot of techniques how to do it. But when you start to do a lot of rhinoplasty, what we are all seeing in our practice, it's so-called pinched nose. And you see it in these patients. It's not only this inverted V. This is there's a lot of problem, and this pinched nose appearance. It's also a functional problem with a collapse of external valve. And when you open the nose, you see exactly, this is an interesting picture because you see where the upper lateral cartilage is, but you see the orientation of the ala. What Dean was talking about, I will show later his article, which is a very, very important, and means the caudal border doesn't support alar rim. You can see it in this case also. There's no support. It's a vertical orientation. It's a vertical orientation of the alar rim. And you see the appearance like literal like a pinched nose with all those aesthetical problems. There's a lot of patients like this. And this is a lot of suture, how we are doing it, there was this so-called dormal suture with a horizontal matter suture. And in all books, you can see it. And how is using it? And in some cases, I got a pinched nose. And in some cases, it went good. But if you see exactly this from other book, this is a horizontal matter suture. And this is what happens actually. And you see where the caudal border is. It's almost straight. There's no support. There's literally no support of the caudal border. And you can see it also here what happens. This is a before, it's a screenshot from a video of one surgeon, and then they placed this horizontal matter suture, is placed it a little bit below, and you see what happened. There is no support, there's a verticalization, literal verticalization of it. And let's see what's going on. Let's take a look on it, because Dean wrote this great article in 2006, and which changed literally, I think this is the most cited article in the rhinoplasty. And if you take a look what's going on exactly, when you place a suture like this, the second bite very, very frequently pull your caudal margin down. It pulls it down. And you can see what happens. This is Ron Gruber's article 1.5 years ago. Also, Barish is talking a lot about facets and also these polygons. And it's a closing the facet. It's a closing the facet in this region. And so you're creating this pinched nose appearance. And this is this famous article from Dean, which changed literally, it was a shift. It was a huge shift in our mindset, how to think about noses, why all those problems are occurring. And he created this slightly oblique horizontal matter suture. I did it in a lot of cases, but not always. Not always it worked for me. And this is Serbian language below. 10 years ago, 11 years ago, I started to think, how can I change the position of my suture entry points? I started even to do the place of vertically here, but it squeezed the nose too much. And I realized I should do something else. And I realized if I change the position of the second bite, instead of placing it a little bit downwards, if I place it 1.5, 2 millimeter, it's going to pull much stronger than any other kind of suture. And this is what we call a cranial tip suture. Barish is using his hemitransdermal suture. Barish and Ron Gruber do it, but for me personally, I somehow started with this cranial tip suture, and it moves. For me, it was one advantage is because the second bite is a flattening. It's literally a flattening across, which you can't use it always. There are some cases you have definitely need a lateral crural struts. This suture doesn't solve all your problems. This suture can solve your problems if you tip it a little bit. If everything is perfect, the orientation of the ala, and I'm a big believer in the alar position and transposition, and I'm using a transposition more than ever. But in some cases, it's very, very important to have this cranial tip suture. So it's creating this diamond shape, what we all of us want. It's making a version of the caudal border and is flattening the dorsum. It's a very, very useful suture. You can see it here on this area. Rollins started to use it also, and you can see it in this drawing exactly when the entry point is number 1, number 2, number 3, and the number 4 from his book. Aaron is, a lot of people are using it still here, and it's an old video of mine, so you can see how I'm placing a suture. I think it's a 10 years old video. It works excellent. And then you go, the second bite is approximately 1.5, sometimes 2 millimeter behind. And then look what is going on with a caudal border. Take a look on the angulation and eversion. It's very, very powerful suture, and it flattens the dorsal.
Super.
There's an angle, Barish, he's got his resting angle, which is relying on the apolateral cartilage, and a very, very interesting observation, very good observation. And the low lateral cartilage, for me, was easier to have a septum, like one structure, which is a straight in the middle, which is easier for me to think in this direction, to have one structure, which is a straight, and then to rely on some other areas. And if I'm trying to create in a thinner skin patients 135 degrees, and if the skin is thicker, I try to get a 105 degrees orientation, because skin is going to pull it down in some cases. And you can see it here before and after. What happened, Dean is talking about the supratip area and recreating this triangular shape below. And you can see in this case, orientation, it's approximately 130 degrees in this particular patient. And I would like to show you this video is interesting because I was thinking, oh, it looks good. It's very, very good educational video. It's better than an older video. The first entry point. And then the second point, you place this behind. This is how it works. And then I pull it, wanted that my caudal border everts. But take a look what's going on now, because it didn't work like I wanted. Sometimes you should show, sometimes when you fail, I pulled, but the eversion was not like I wanted. I was a little bit more eversion. What happened in this particular case, I ignored this posterior part, that there is a cartilage. And in 22% of the cases, there is a direct connection. So it came permanently to the spring effect in this area. So my dome comes back. So in some cases, I'm going to show it to you, there is a connection. In 22% of the cases, Peter Palhazy and me, we did an analysis of 200 cadavers. And in 22% of the cadavers, there is no cartilage between, there's a direct connection. This is just one cartilage in this area. And you see this is a scroll cartilage, which is has a different orientation. It goes not like you see in Anatomy Atlas. It supports your low lateral cartilage of collapse, and it's open external valve, and it can be big. And if there's a connection here without any interruption, you should cut this connection to prevent, to avoid, to allow your caudal border to evert. And you can see in a lot of patients this, and there's a lot in 70–80% of patients, there are several cartilage, sometimes 3 cartilage. They can be big. You can see them here. They can be like in this case, almost 3.5 millimeter. And we should learn to deal with them. If the cartilage is very, very thin and flimsy, you should support it. Either you can use this Osman flap, a cranial turn-in flap, or you can place a piece of cartilage with like a small graft to support this area. Eversion is very, very important, but if your caudal border is very, very short, you're not going to get this version like this. You can see it exactly. And if you see, this is a beautiful picture from Instagram, but you see that this caudal border is without any support. It's not going to support our caudal border of caudal rim, and that you are going to get a, there will be much higher. So we need a support in this area. And what a lot of us like, this Lana Del Rey beautiful nose, it's a support of this area, and that there's a transition there between a tip lobule and an alar lobule. And you should think about Dean's computer picture, generated computer. I think you run several hundred models, and this is a very important that we should try to avoid demarcation line in this area and to create some kind of alar light reflex in this area. And this is the only one thing which I rely on the table. Everything can change, but this is a very good sign. If you have this alar light reflex on the table, it means that your alar rim is supported enough. You can do it via transposition. Sometimes it's enough that you do eversion, or sometimes you can do other grafts like articulated rim grafts. And you see, in this case, if you would do eversion in the upper case, this caudal triangle, this is a Rollins turning point, this is a caudal triangle, is going to support the alar rim. But in these cases like this, we can do eversion, everything, but alar rim is not going to be supported, except alar lobulus is very strong and the skin is very thick. In this case also, they're completely two different things. And in this case, I would personally go for a transposition, and with a very frequently with lateral crural struts. That means we should be aware of this. And we need to support this area, especially between the middle of the alar lobulus, which is a very neglected structure, and the tip lobulus. That means we should have placed rim grafts, different kind of rim grafts. This is my patient. If I would leave it like this, it's everted. But in this very case, I would get a problem with my alar rim. So I did an articulated rim grafts, described first time from Rick Davis. Normal rim grafts were described by Rod Rorik, which is also a great thinker. But if alar lobule is less expressed, if you have a very thin skin, you can't use normal rim grafts. You need this spring effect of articulated rim grafts which open the external wall. And it's open literally, and you can use it like an overlay or underlay. In some cases, you can make a small pocket, stick them inside, and because you don't want to change appearance of your tip, which is very important. In these cases, the tip is nice, but you see this polygon, this bearish wood, it needs support in this area. So in this case, I used a graft like this, underlay graft, created a pocket. Can create bigger pockets, bigger grafts, but be careful if you're using articulated rim grafts from a rib. In this very case, my graft broke, and you should be very careful how to stick your grafts, or when you do orientation of alar, because alar rib cartilage could be very rigid, and it's a problem. Alar lobulus is very important structure, but it's mainly, this is a so-called tila subcutanea cutis, but which is described several centuries ago. And we thought in the first moment that the tila subcutanea cutis, they're creating and supporting this area, which is definitely not true. It's an outer skin layer, which is supportive and thick, and it gives a thickness and support. And for me personally, articulated rim grafts, we should think about how big this articulated rim graft should be, because we don't have always a cartilage, and we don't need always such a lot of cartilage. And if your graft is too long, you're going to open the valve, and then you can have a problem. So for me personally, the best thing is, this is alar lobulus, this is an alar lobulus, and this is a half of alar lobulus. I try to create my articulated rim grafts that go approximately the length, 60% of the length of my alar lobulus, trying to prevent this widening of alar lobulus. And then I stick these articulated rim grafts inside. In this very case, I needed to do additional tip graft and then to insert it very, very carefully in this area. Then on the table, you see this alar light reflex. It's opening. That's here before. You see this demarcation line. You don't have always to do transposition, but it's a very, very useful. It's here after. About 11 months, is still a little bit swollen. After, before, and after. And the alar lobulus in every patient, this alar lobulus is very, very neglected structure. We should think about it that this skin, very, very thick skin in this area and in this area are different. And the tila subcutaneous cutis, they're muscles and fibrofatty tissue. They're useful. And think about them. How can you use it? Because if you do the transposition, this is a transposition case, for example, and this is before and this is after, and you see how wide suddenly this nose became. So the surgeon, he needs to take a piece of skin here instead of, okay, we are going to rethink how much cartilage we need. Sometimes you need a bigger graft to go to the apertura piriformis, but sometimes it's not necessary. Use your alar lobulus as a supportive structure, and sometimes you don't have too much cartilage. It's a think about it when you use articulated rim grafts or lateral struts. And this alar light reflex is it's a good guideline in this area. And this so-called demarcation line between alar lobulus and tip lobulus shouldn't be wider than 2.5 millimeter actually. And so you can see I showed it patient before. She's got this very, very nice light reflex. You can see it. There's no demarcation line. And if in some cases, if you would go for extended cranial dissection, it is going to have a retraction. Take a look how retracted it is. And supporting this area is very, very important. These cases are here. I did a transposition in this case because we have to support this area. That's her, the articulated rim grafts. It gives you, it's open. This area looks much better. I'm not so good photographer, unfortunately. Sometimes you have a caudal, you need to do caudal resection. I think Boris and me were the first one. He was started to think parallel. It was interesting. I think it was 2012 in Istanbul when we started to talk. Oh, I have the same idea. We started to do it was the holy cow to do caudal resection. It was very, very important. In some cases, you need to do caudal resection to get a good result. And you should support in some cases. Even this eversion, you can sometimes deal always, and you need support of this articulated rim graft. Like in this case, I need to place it in this area. It was a rib case. I put a rib, and I did a let down in this case. And it was a very, very interesting case. At the very end, she's got a much better result because it was a combination of the let down and the rib case. Sometimes you can see exactly on where you should put all those polygons when you should put and support it. So cephalic resection, we are thinking always about cephalic resection as necessary and how to do it and leave 6 to 10 millimeter. And we are thinking always it should be quadrangular. And we've seen all those books, and this is a Ron's instrument to put it on the table, how your beautiful tip should look like. And we see that this structure in this area, the tip has to be quadrangular. And my problem I had in some patients where the tip didn't looks like this, and look well. And this lady, 8-9 years ago, she made a huge impact on me. When I opened this nose, what I have seen, because her tip was beautiful. It was a very, very good looking tip, especially in this area. And this shape of the cartilage was a triangular. It was interesting. I did a surgery, just a resuture tip, septal extension graft, etc., etc. She looked much better. And I started to observe the patients with a beautiful tip. And what I have seen are many patients with a triangular shape, which is a very, very interesting. And more and more and more. And in all those cases, I didn't do anything. As a patient with a beautiful tip, I had to do only bony work. Barish would definitely go endonasal, which he can do great. And I started to do a measurement. I didn't cut anything here. The tip was beautiful. And you can see that from this point, the tip is approximately 2.5 millimeter. And from this point to this point, approximately 6 millimeters. And when you create a tip, when you have some problems, maybe some measurements to have in the head is very, very good. And in a Caucasian woman, average woman, I leave usually approximately 3 millimeter to 4 millimeter, depends on the skin. And this diversion line and this triangle started from this point till this point are approximately 6 millimeter as orientation. So we can do this cephalic and caudal resection in some cases if you need it to create a beautiful tip. And if you see the tip like this, if we would leave it like this and do only cephalic resection, the excess in this area is still there. And so we need to start to think a little bit out of the box, that not only cranial cephalic resection is necessary, also caudal resection, and we need to recreate. The cartilage in this area was very, very thick, and if I would leave it like this, I could see some irregularities, and I would have a problem because patient could see exactly all this cartilage. So what I did so-called shaved cartilage. You shave the cartilage with a 15 blade and connect it with a PRF and placed, it's a fibrin, patient fibrin gel. And I just resuture it to keep this shaved cartilage in situ. You can suture it without any problem. And it stays here. And it's one of my first letdowns. This is an interesting case when it's about tip. When I have seen her, I thought, okay, this bulbous tip, it's going to be relatively easy case, not a huge problem. My big problem would be how to straighten it. I'm going to do the suture, or do I need to do reposition, or do I place lateral crural struts, which are very, very useful. And I opened the nose and suddenly I had some kind of accordion. Everything was squeezed like this. And I said, okay, this will be interesting now. But I had these measurements in my head, which made my life in this moment a little bit easier. So what I did, Barish popularized this maneuver, this Lipset maneuver, when Rick and Barish did a great contribution with this interesting combination of tensioning of our low lateral cartilage and this overlapping in a crus medial, which is a very, very useful. So this is a tensioning. This is a dome where it was. This is a new dome. So you remove dome literally forward, doing medial overlap, and we are doing triangular resection. So unfortunately, the picture with an onlay graft in this area didn't succeed. I draw it for you, and this is how it looks after. What we did, you see this is overlapping, it's a tensioning. I did a slight eversion. In this case, lateral crural steel also, and you see it before. This is a tip before, and this is the same patient after. And I say this is a small onlay graft on it. So if you have all these measurements in the head and you know what to do when you have a nose like this, and to say, okay, this is from here to here, where I should do a triangulary, should be approximately 6 millimeter, and here, depending on her skin, approximately 3.5 millimeter triangular shape. You know what to do. It makes your life easier. It's her before very, very thick skin, 1 year after. Very thick skin, and it's a strong septal extension graft. And you can use it in several options. This is this tensioning of the nose, literally tensioning and recreating. This is a dome, and the new dome should be here, approximately medial overlap, and it gives you very, very nice dome appearance. But the problem is, if your cartilage is very, very rigid, like in this case, this is interesting because all these maneuvers could get you into trouble, because cartilage can break and you can have problems if there's some notches in this area shown pre-modeled domes. So you can use other option to do your triangular shape, but you're doing overlapping approximately 5-6 millimeter behind of your dome, and then your cartilage slides over your part, your low lateral cartilage slides forward towards your dome, and it's supported by this underlying cartilage. That means this is an old dome, and this is a place where you're going to cut, and you release it, and you see immediately, like when you release it, like your cartilage is overlapping this area, and this is going to give you support, because the standard dome division, you're going to have a pinched nose, you're going to go into the trouble. And then you can create your domes to cut. If there's too much cartilage, you can cut this part, and then you can go from here to here. If you have all those measurements in your mind, you can create domes like this. Unfortunately for me, I was thinking, oh, I'm smart, I have another idea, but this is an idea first published by Calvin Johnson. I found Dean wrote together a book with him, and Calvin Johnson, there's a small drawing, and I was reading 1 year ago this book, refreshing, because there's a lot of books you can find some interesting details, and unfortunately at this moment I was disappointed. So this technique should be contributed to Calvin Johnson. He was the first one who published it. So before and after, before and after. She's got a very, very rigid cartilage. Before also and after. And I think this is enough for this. This is a Hamburg port, very, very beautiful. It's a new Philharmonic. It's never so beautiful like a George Marcel Sydney Opera, but we try to do our very best. Incredible. There's some people still there.
Yeah, amazing, Professor. We have almost 250 people, and they're here since the beginning, and it was amazing. Thank you so much.
There's just a small part. The huge part is actually, I didn't want to put it, it's a transposition, and I use only one new idea, which is a very, very good, is that you can use this caudal triangle, like a caudal turn-in flap, to straighten your low lateral cartilage. And then you don't need always, and you can do your reposition, you don't need always lateral crural struts. It's interesting. But if necessary, take lateral crural struts and do it. Barish is doing some new techniques here. You should see Barish, how he's dealing with some problems. There are a lot of new ideas.
Yeah, Boris is still here. I've been with him like 3 times, and he's so skillful, so talented. I tried to copy him, but it's
Boris is here. Oh, Boris is here. Boris is here. He's listening.
Hi, Boris. Please make your comments.
Thank you very much for asking me. I listened to the lecture very carefully, and I like it. And especially only 2 minutes ago, Dr. Milos showed a very good example, very long, convex lateral crura, and he used the lateral crura steel and the medial crura overlap, and the tip was amazing. So I like it. Thank you very much, Dr. Milos, and also you refer my name a lot. But what can I add? Yeah, already we know there's a lot of technique in the literature, kind of resection, suture technique. So we discussed with the Roland Daniel 7 years ago. He pushed me to describe the ideal shapes. So I focused on the empty spaces. What can I add? Also, Milos showed very well the divergence, the empty spaces between the medial crura, the resting angle. Also, it's very important.
Definitely.
I can add 2-3 things. What I do for the caudal excess, yes, bulbous tips in European noses. Excess cartilage has also caudal excess. What I do, I don't resect it. I use it as a flap. I incise, I do marginal incision, and I left the caudal excess on the skin. It's really work, but it works with the lateral still.
Definitely.
And the divergence is very nice. I don't want that anything. I do exactly the same as Dr. Milos. Also, I can add the scroll ligament support to this area. It's a connection between the nasal mass to the scroll area. So it works like a barrier. It's a stopper. So lateral crura cannot go upward. So scroll ligament push or keep the lateral caudal aspect in place. So also it's guaranteed the resting angle. So only what I want to add. Thank you very much for lecture. Thank you.
Thank you very much.
Thank you, Bart.
Just a short 10 minutes lecture about if there's a more question.
Yes.
I prepared some dessert for you.
Yeah.
Very short dessert.
Yeah. The last like
10
minutes.
minutes.
At the beginning, the last 10 minutes are the most important.
Yeah, of course.
Yes, please.
Wait a second. Yep. Here we go. And I have to find a Zoom. How to open. So I have to find a way how to start. This is okay. Well, so this is one interesting what we are working on it since more than 1 year, and the question was, can we accelerate healing after rhinoplasty? That was a very interesting question for me, because you see those patients and say, doctor, how long is my nose going to be swollen? And everyone knows this almost passive aggressive look. First, you are not 100% responsible for this swelling. This is the most important thing. There are 3 things that they say all my patients, which determines your results. It's your anatomy, my surgical skills, and the healing. And we can't control healing. This is a very important thing. But you say to the patient, okay, it's going to be swollen a few months, 1 year or 2 years. But in some cases, we realize after 1 year or 1.5 years, this is not just a swelling. Patients come to you after 1 year, you squeeze the nose, she's squeezing the nose, and you feel this special puffiness, which is not an edema. You feel it's a much more stronger, and it's a fibrosis. It's a fibrosis in some cases. And this is especially in the patients with a thicker skin, medium and thicker skin. Even if you go you prevent, I try to go subperichondrial, Barish goes subperichondrial, but what we try to do very gentle and to stay in the layer, to be very gentle surgeons. And there's a lot of so-called lymphostatic fibrosis because this edema is created there and it stays there. And this is what creates in some patients a lot of fibrosis. Yeah, what we can do? Can we influence by the healing process? Can we do it? We can close the dead space. Barish did a great contribution with a Pitangui and scroll ligament readaptation. But in some patients, even if we are doing this, still there can be a problem. And I asked to myself, okay, what can I do? And we created together so-called Hamburger protocol with the University of Hamburg, something which made a significant impact of the appearance of eye patients. And lymphatic, we do lymphatic drainage 14 days before surgery. They start to open the lymphatic waves for 14 days before. We are giving prednisolone during the first phase, which is approximately 3.5 weeks. And in the patients, when I'm doing so-called defatting, then I give Potaba Glenwood. It's a, I think someone started to do some interesting drawings on the screen. And please, Fernando, can you ask someone to remove it? We had it in Iran. Iranians are doing it. It was very, very interesting. Charles East was giving a lecture, and somebody started to make a drawing from a sky and the clouds. So it's nice. So we are starting to do lymphatic drainage first in this supraclavicular area. You show the patients, we have a video on our website. Then in a neck area, you remove literally like you would remove a liquid in this area. You go slowly and you teach your patients how to do it. You open, and then in this area around the nose, and it gives you significant amount of contribution that is less swelling. And this is what you can do, all of you screenshot. We talked to the two different departments for endocrinology. And we started, everyone said, oh, 200 milligram prednisolone is not too high. No, it's nothing going to happen. We have more than 185 patients, which we are following and given it, and we're giving it for 3.5 weeks. Of course, we are giving PPIs inhibitors, omeprazole or pantoprazole or whatever, to decrease the level of acid. But this is a very, very important. And as said, made a screenshot or text me, I'm going to send it to you. When I'm doing defatting in several patients, I have seen a fibrosis. So I started to look after in a university clinic of Hamburg. They gave me medication, recommended medication where we're using for morbus Dupuytren. You know, it's a contracture in this area. As a plastic surgeon, you have to know, or urologist using this for prevention of induratio penis plastica. That means this is a medication which prevents fibrosis, and I use it for 2 weeks. After, when I'm doing a manipulation, you have people with a very, very thick skin, and sometimes you should do a gentle defatting. And this is what I'm using if I can't close all these sutures and ligaments, and I have to do defatting, then I'm using this medication. And you can see in some patients before and after surgery, this, you can move it, literally how it was being used to see that she can't move. This is a skin mobility test. And it's already healed, and she's already 1 month after. 1 month after, and it sticks literally to the skin. Usually in revision cases, I'm using a fat layer with a PRF. It's very, very interesting. We don't have a time for all those things. And in these cases, you can see that this is this dot, and she tried to move this dot, but the skin mobility test was negative. The skin mobility test is negative when you can move this dot more than 4 millimeter laterally and 2 millimeter vertically. It's she's 1 month post-operative, but it's already got the results after 1 month. Everything sticks. There is no edema. There is nothing. This patient is a before surgery. It's a before surgery, and you can see how he can move this dot. And this is very, very interesting in all my patients where I placed this layer, recreated layer of fat with a very, very thin or a problematic secondary skin. All those skin mobility tests are positive. And in a thin skin and a damaged skin, if I don't do it, I have seen a lot of patients with the contractions, and then you get the problems also with the skin. This skin mobility test is interesting, and this diced fat, I diced fat literally, take it from an umbilicus, make a layer, drop several drops of platelet-rich fibrin, connect it, and place it above. Dean is using, he was one who inspired me with his Mystine injection of nanofat into the temporalis fascia, but I tried to went a little bit different way and literally to recreate a layer of the fat, the missing layer of the fat, and it worked. Sure, and it's 1 month after. She looks almost everything like a surgery is done after 1 month. Her also 1 month after. In those days when I was preparing this talk, it was 1.5 months ago, 2 patients stopped taking prednisolone because of emotional disbalance. They feel the flash, that they were nervous, and we said, stop. And we had 3 patients with a very, very thick skin with no significant effect. We observed that in 8 patients, after 1.5 months, the swelling started to cure again, and we gave them prednisolone for 12 days, starting with 100 milligram. And so we could decrease literally the swelling and to have a huge impact on the healing. So we can literally do acceleration of healing. And I'm working with Robin Williams from Harvard University, with the Robin, and a university clinic in Hamburg, in Germany. The further studies we are working on it, and with MRI, etc., etc., etc. Be careful of the post-rhinoplasty fibrotic syndrome, because to get rid of all those scars in this area is very, very problematic. And you can not only resuture all those ligaments, but you can make a more pressure in the supratip region to do the tapes a little bit differently. And if you place it here, exactly in the supratip area, and then a new plaster above to do more pressure in this area, you're going to close even more this dead space. And this is how on top come the cast on, and this is, you can prevent even more a dead space. There are several other options, but this is one of the options.